Welcome back, listeners, to another episode of Ultimate Potential, a mental health podcast. I'm Tony.
And I'm Craig.
And we are here to blind you with science. And today we have a really wonderful guest with us.
Thomas Dolby.
This is Margaret Oak. And Margaret, is it Margaret Oak Bailey?
It's Margaret Oak Bailey.
Margaret
yes.
Oak Bailey.
Yes,
But
I am married.
But when I first met Margaret, it was Margaret Oak, because Margaret and I went to graduate school together. Margaret is a clinician. We're both licensed marriage and family therapists, so we go way back to when we were wet behind the ears.
Oh, yes.
And Margaret is kind of, in theater they call it a triple threat. If you can sing and you can dance and you can act, that's like a triple threat. She's kind of the triple threat of the mental health world, because she is a former therapeutic consultant. She is a licensed clinician. She is a former residential treatment center employee therapist. She's actually a quadruple threat, because she is also now the owner of a chain of intensive outpatient clinics, which we're going to be talking about today. So welcome, Margaret.
Thank you. I appreciate you inviting me.
Yeah.
We're excited to have you. We have lots of fun questions. And just remind that we are here, like the whole idea of this podcast is to help families, help people who may not have the connections that they need, right, when they need help. So we know that you are a fountain of information and knowledge and actual treatment options. So we're excited to have you.
Well, thank you.
Yeah.
Could you talk, maybe I just really skimmed the surface of your background. Could you tell us a little bit more about your history and your background?
Yeah, absolutely. So after I graduated with my master's in marriage and family therapy, I started working in a residential treatment center here in Utah. I was there for a decade, and during that time I was a therapist, staff therapist, and then I started doing the parent weekends and doing a lot of keynote speaking there. And the last few years that I was there, I was director of admissions and marketing, while I also maintained a small caseload. So then I moved over to educational consulting, but mine was specifically therapeutic and crisis consulting. So I only worked with mental health and crisis placement kind of stuff. So lots of almost interventional work there. I did that for a decade. Yeah. First 3 years were in Austin, Texas, which was a fabulous time. I always tell people you don't go to Austin to see things. You go to Austin to eat things and to hear things.
Yeah.
And boy, did I eat and hear a lot of wonderful things while I was there.
That's good.
And then after that, I broke out on my own, went to Southern California, and I was in Orange County and consulting there. And while I was there, of course, I met and married the man of my dreams. And we shortly thereafter had a child. So we have a 7-year-old and a 20-year-old. And life is fabulous. And after my baby was around 2 or 3, I think, is when I realized the life of a consultant, which is on call 24 hours a day, wasn't very conducive to being a full-time mom or a hands-on mom. So I went back to private practice at that point, really started to focus my career on trauma. And so got trained in EMDR, eye movement desensitization and reprocessing, which is kind of an umbrella for trauma treatment, because these days we do more flash technique, more progressive counting, because it's faster and as effective, where EMDR was already about 50% faster than the next most effective.
Right.
This is, I'd say, at least 30%, 40% faster than EMDR.
Wow.
And so I got trained in that, really got into it, and I then became a trauma intensive specialist. So I'm a certified trauma intensive specialist, which means I work with one client 6 hours a day, consecutive days, until we break through that trauma.
Wow.
We break through that logjam that's just holding them back in therapy, where and a sign that you're ready for an intensive is that you've been going to therapy, you've made some good progress, but you keep having to put out fires. Things keep coming up and you're just not able to quite reach that end goal. And so what you would do is come kind of like a therapy retreat and do that for a week or two, during which time we use that EMDR, the internal family systems, the parts work, attachment stuff, as well as the progressive counting and the flash technique to really iron out the roots of trauma and the sequelae of trauma throughout your life.
That's
And then you
cool.
go back to your regular therapist for what I consider to be the small change. How am I going to live my life now that I'm not reacting
Mm-hmm.
to trauma in the past, in my relationships, in my career, in the risks that I take, that kind of stuff? How am I going to live my life now
That's
that
so
I'm free of
cool. I,
trauma?
I love the state of our profession is advancing rapidly as we learn more about the brain. And I mean, it used to be for so long you had really just psychoanalysis, and then came the advent of family therapy and that
Mhm.
specialization, and and then it was just kind of individual family therapy for a long time. But I actually didn't know, like every month there's a new type of specialty that's really effective. I didn't know about trauma intensive
Yeah.
certification. So this is somebody that's been traumatized, been working on it, but there's kind of a log jam
Mhm.
and they just get stuck.
Mhm.
And you come in as this deep dive intensive intervention, and you just grind away at working through that until it flushes out and
Mhm.
that person is able to get to a new level of functioning
Yeah,
and move
really
on.
level up in their own lives to where they want to be. Where, like I
Mm-hmm.
said, those kind of monsters that have been there that they've
Yeah.
been ignoring.
Yeah.
Because if we talk about trauma, let me go into trauma just a second and
Okay.
say the theory to which I ascribe is that we live our lives, we go throughout life every day, and we live our lives, and life happens,
Yeah.
and every night our brain processes, it
Yeah.
chews up everything that happened during that day
Yeah.
and moves it from short to long-term memory.
Mm-hmm.
The only problem is that when something shaming, terrifying, rejecting, something really hurtful happens that day, it's like a lump of bad meat that your brain can't chew up and move
Okay.
to long term memory. So it's sitting there in the middle of your brain, this painful thing that we don't want to look at, we don't want to think about, we don't want to touch. It's too painful. And so every human basically builds a wall in their brain and takes those lumps that happen, every once in a while and throws them on the other side of that wall and just pretends like they're not there,
Mm-hmm.
which is a great short-term strategy. But each one of those lumps represents a trigger.
Yeah.
So that means when I go through my life and I may have a lump from being abandoned or feeling abandoned when I was little, and maybe I break up from a significant other in a
Yeah.
romantic
Mm-hmm.
partnership, somebody else who hasn't had the same trauma that I have is going to react like this. They're going to eat their ice cream and they're going to mope and they're going to cry and stay in and watch Nora Ephron movies, and that's fine.
Uh-huh.
But because of my trauma, I'm going to be up here. Life is
Right.
ending.
Right.
I can't
Yeah.
handle it. It's too
Right.
much. And so that's going to affect me going into future relationships because I remember the pain that I had from breaking up
Right.
from this one. So I'm probably not going to give up as much as of myself in future relationships. I'm going to protect myself. I'm maybe going to try to connect with people who aren't so great at connecting
Mm-hmm.
because I don't want to get that close again and be
Right.
feel that pain. So what we do with EMDR is there are special ways of talking about and thinking about those memories at a distance. Because I got to tell you, before I was doing EMDR, I was doing the next most effective thing, which was titrated exposure to traumatic memories.
Mm-hmm.
That means every session I'm meeting with somebody, and one session we're talking about what did you see during that memory?
Right.
What did you hear? What did you feel? What did you smell?
Mm-hmm.
And when you're working with a 13-year-old on a gang rape,
Yeah.
that's like pulling your own skin off
Yeah.
Right.
for me, let
Yeah.
alone my client.
Right.
So if you're not in residential, the retention rate is abysmal. You
Right.
have huge dropout rates because it's
Nobody wants
just
to come back
who
and do
can
it.
tolerate
Right.
that,
Yeah.
right?
Right.
I, as a therapist, am not looking forward to these sessions.
Right.
They're
Right.
it's horrible.
Mm-hmm.
And then when I discovered and became adept at EMDR, it was like everything opened up. Then I felt like I was a real therapist,
Yeah.
and I was 20 years in at that point,
Mm-hmm.
and considered a good therapist before, objectively.
Yeah.
Right.
And now I'm able. I can go in and I can promise people, you're not going to suffer with this anymore.
Yeah.
And we're going to do the prep work to get there. We're going to slay that dragon. And then you're going to live a life free where you are proacting and you're not reacting. You don't have these lumps that are causing you the traumatic triggers that you had
Right.
before.
Yeah.
So that's where I, as you mentioned, the work is moving forward so quickly. I was doing the most effective thing up until I got into EMDR. And since I've gotten trained in EMDR, now I'm moved on to flash technique and to
Right.
progressive counting, where I can go into a session with somebody. And I have people that I worked with 10 years ago coming back to me and saying, I just had a bad breakup. Can we do a session? And we'll come in and we'll do progressive counting. And they walk out free of that burden.
Yeah.
That's
And
nice.
it feels really nice.
So for our listeners, the gold standard for the longest time for trauma and phobias was something called exposure response prevention. And it's essentially you take the thing that you are distressed over and you expose your patient to that. And then you help them work through that traumatic response. And as you do that over and over again, with increasingly more kind of intensive exposures, then that client develops the ability to cope with that in a really systemic way. I've been reading more and more, though, about there's some criticisms to that because inherent in that you have to kind of re-traumatize
Right.
You're
your
re-exposed.
patient, right?
Yeah, it's
And
happening
so
over again.
going back to my earlier comment about how cool is it that in this profession we have these advancements where we're able to work on trauma now in ways that don't necessarily have to reopen that wound over and over again as it's trying to heal, right?
And one of the really cool things that I liked immediately about EMDR is I don't even have to know what you're processing.
Mm.
You can
Right.
say the thing that happened in the blue room.
Mm-hmm.
I don't have to know.
Right.
And then you work on it and I guide you in working on it. But it affords so much privacy and so much distance from it. And it's just as effective as if I heard every detail
Mm-hmm.
and processed every little smell and
Right,
hear and
right.
feel.
So we've talked about this intensive certification, but you're you're doing a lot with intensive outpatient right now.
Yes.
And I don't know that all of our listeners know what that is. Could you talk maybe a little bit about what is an IOP,
Mm-hmm.
and when would somebody want to look into that?
Yeah, absolutely. And this goes back to when I was consulting. A lot of what we did was educate families about levels of care and the spectrum of care.
Mm-hmm.
Down at the very bottom, you had, a school counselor or
Mhm.
a priest or whoever.
Yep.
The next step up from that is going to be weekly therapy,
Right.
where you go sit down, talk to a therapist.
Typically an hour.
Exactly, typically an hour. At the very far end, you've got psychiatric hospital, you've
Mhm.
got wilderness programs, you've got, and then, residential, and there's a wide range of residential acuity as well. So stepping up, a lot of what people don't realize is there is if 1 hour of therapy a week isn't enough for you or for your loved one, you don't have to go immediately to residential or to the hospital. Unfortunately, because there's this lack of awareness of what's available in between, people are holding on too long or just stopping weekly therapy until there is the crisis that gets them admitted to a hospital. What's really cool, though, is there's this other level of care in between. There are actually two. The first is intensive outpatient,
Mhm.
which is typically 9 hours a week. And then there's partial hospitalization, which is typically 6 to 8 hours a day, weekdays.
Right.
Hmm.
And so that's what my husband and I have really been interested in is this level of care that is between weekly therapy, 1 hour a week, and residential or hospitalization because it's accessible. So we're talking 9 hours of therapy a week. That's 3 group sessions where you're meeting with people with similar issues, similar age, and a therapist, and you're learning skills and you're processing. And then once a week, also, there is a family or an individual or experiential hour added to that. So that adds up to about 9 hours a week. And it's incredible what we're seeing in this. And I have to tell you, the reason that my husband and I, as veterans in this field, we were aware this level of care existed. But a little over a year ago, our 20-year-old son had a mental health crisis.
Mhm.
And we were looking for something for him.
Mhm.
We knew weekly therapy wasn't enough. And so we remembered, okay, IOP, we cast around, talked to some people and found, oh, wait a second, there's one up the road from him in his college town here in Utah.
Mhm. Mhm.
And so he got involved in that and in a couple other kinds of therapy at the same time. But really, IOP was everything for him.
That's
It did it
cool.
for him.
Margaret, it happened to me too.
Yeah.
My son, when he was 21, he had this crippling anxiety and OCD, and we had done outpatient therapy forever, and it was just almost like you have an infection, a full body infection, but the dosage of antibiotics he was on was just
Mm.
not quite enough, and so the infection persisted. He wasn't getting better. And so he actually went out and found an IOP. He researched it. He came to us and he said, "Here's this place. It's more intensive than what I've been getting. His was actually 3 hours a day, 5 days a week. And I know there's a little bit of variation in IOPs on what days and exactly how many hours. but it did the trick. It was, he just needed that higher dose,
Mm-hmm.
right?
Mm-hmm.
This is the sad thing. You know, we've all worked in residential programs, and we've all had families that have come to us, and they leapt over the IOP and the PHP level of care.
Right.
They were in an outpatient therapy, they were struggling, and they just took this huge leap right to residential
Mm-hmm.
treatment. Now, sometimes I think it's warranted if you have a really scary
Safety
life and limb
concerns.
safety issue, right?
Right.
Sometimes like a suicide attempt, or
Mhm.
Mm-hmm.
or an issue with an eating disorder. You know,
Or
it warrants,
sneaking out,
right?
stealing, those kinds of things.
Yep.
But all too often we have these clients come to us and they never tried IOP,
Right.
and it's like, man, we have this ethical obligation to try to do the least restrictive environment possible.
Mhm.
It's like a
As an
medical
consultant,
doctor,
that's
right?
what I did too.
A medical doctor, their ethics is, if you have a heart condition that can be treated with medicine, then you're not going to do open heart surgery, right? You
Mhm.
only go to the more invasive thing if it's absolutely necessary. And so people really need to take this seriously and ask themselves the question, is an IOP something that I should be looking into before leaping to something else?
And one of the reasons that we felt so strongly about it is because of that accessibility. It's, there are IOPs in most areas of the
Yes.
country. Insurance loves IOP.
Yes.
They love the least restrictive environment. They
Mhm.
love prevention as
Mhm.
opposed to, shelling out for residential.
Mhm.
Obviously, residential is going to be needed for some.
Yeah.
Right.
However, they love this idea. And some of the things also that we love about it are you sleep in your own bed.
Yep.
You're not separated from your support network.
Yeah.
You can continue to go to school or work if that's, you're able. And you get to practice the skills that you're learning in the real world
Right.
environment.
Right.
And then have this safety net, this scaffolding of I'm going 3 to 5 times a week and talking with a therapist and with peers. That's the beauty of it, is because the peers are there
Right.
to hold you accountable and encourage you
They're doing
and
the
mentor
same work.
you.
They're doing the same work. Yeah.
Exactly. It's really wonderful. So we were really drawn to it. And so when a change in career options presented itself about a year ago, we started looking into this and decided we were going to dig in as a family instead of my husband, who's this high-end healthcare administrator, where he was managing 160, 170 programs across the country until a year ago.
Mhm.
Now he's managing these 5 in Utah,
Yeah.
and we are going to grow. And so we are expanding, and that's exciting. Right now, we're in the middle of a name change.
So, yeah, let's talk about this. This is the Anxiety, Trauma, and Depression Treatment Centers,
Mhm.
and the website for somebody looking into these IOPs would be
Anxiety, trauma, depression treatment.com. I think it's just coming live.
Okay.
So it's atdtreatment.com or anxiety, trauma, depression.
we will
.com.
get
Yeah.
the right
Yeah.
website in
Mhm.
the notes, the show
The old
notes.
one on the back is live, and it's going to stay live probably
Okay.
for the next year or two.
Okay, and that's lifelaunchcenters.com.
Yes.
Okay,
Mm-hmm.
great.
That's good. Okay, so you've talked about because you've had experience at all these different levels of care, right? And you've talked about the pros and cons, and you're a mom now.
Mm-hmm.
I know that you have your 2 real children, but hypothetically, you've got say a 15-year-old, and you're trying to decide now between outpatient, intensive outpatient,
Mm-hmm.
residential versus acute, like
Mhm.
hospitalization. Like
Mhm.
here in Utah, it would be maybe Huntsman Center or something like
Right.
that, right? What are kind of the beginning questions, right? So that you talk about, oh, I can sleep in my own bed. That's a good thing
Mm-hmm.
if they're safe to do it, right? And so,
Exactly.
like, can you talk us through maybe a few things that
Sure.
that you would ask our families to consider so that they know where to start?
Yeah, and first of all, I'll tell you that as an unmarried single woman, I was a prolific parent of hundreds of teenagers
Okay.
in both outpatient and in residential.
yeah,
yes,
and,
really
and
are.
people would ask, "Why are you teaching parenting classes?" I said, "I have had 100, 200, 300
That's right.
teenagers."
Yeah.
Yep.
Or my brother would call and complain about his teenagers, and I'd say, "When are they? Are they doing this? No. Are they doing this? No. Are they?" call me when they do.
Yeah,
You know,
right.
you don't really
Right.
have problems. So, the bottom line is, are you trying outpatient therapy? Are you doing once a week therapy? Have you given that a good try? Because that is the entry level, really.
Right.
Are you starting to become self-aware? Are you showing some insight into the problems in your life and what control you have in them, what kind of impact you can have on changing those patterns that are in your life? And if that's not enough, and if you're not developing that insight and that self-awareness in once a week therapy, then you probably want to start looking at stepping up. And when someone who would be appropriate for IOP level of care would be somebody who is their depression, their anxiety is just really negatively impacting their relationships, their school, their former hobbies, family, work, those kinds of things. If they're sleeping too much or too little, if there's a lot of isolation from family, withdrawing. If they're this is something that we noticed in our son, and we've noticed in a lot of the kids who come to us, is if their communication is primarily through text or social media.
Right.
That's the main way they're communicating or interacting with the world, let alone their
even
family.
sometimes their family.
Right.
It just they're retreating from the world. They're withdrawing.
It's too much.
Yeah.
And that's one of the things that we're seeing these days is that kids in this generation, so most of the people we treat are teenagers through young adults. So we're talking young teens through mid to late 20s.
Yeah.
And what we're seeing is most of them are living in survival mode.
Yeah.
Yeah.
Whereas, those of us from whatever we're Generation X, right? I hope
Yeah.
we're not boomers yet. We're
People they call
Generation
us
X.
boomers. We're not boomers. We're Gen X.
We are X,
Proudly Gen
right?
X, yeah.
Yeah. My mom was a boomer. My dad was a boomer. Actually, my dad was pre-boomer. My mom was January of 1945, so she was
Is that greatest generation?
the beginning of boomers.
Okay.
Anyway, so our generation, something bad happens. Yeah, it sucks, and we take an emo day and we get back in the race. Whatever.
Right.
This generation, they're living in survival. So something bad happens, they don't have that try again.
Yeah.
It is, everything is over when something bad happens.
It kind of goes back to what you're talking about with trauma and the bad meat and the the compartmentalization and the fight or flight.
Yeah.
Yeah.
And we're seeing that so much in these kids is they just don't have that resilience. They don't have that grit. We talk about these things.
Yep.
Yeah.
These are kind of buzzwords that we talk about, but it's really true. They don't have the resilience to say, I've fallen down or I've been knocked down and I know what I can do to get back up.
Right.
Or even the belief that I can get back up.
Right.
And so that's really what an IOP is good for. Now, there are specific IOPs for specific kinds of things, and ours, of course, is named what we do and focus on, and that's anxiety, trauma, and depression. We're in the process of getting our therapists trained in EMDR, and eventually we will be offering these intensives at our locations. We're on the way to that right now. I'm the only one who's able to do that, and I don't have that much time.
Yeah.
So as far as how do I know if it's IOP or residential or a hospitalization, I'll tell you what we can't take, and that is primary eating disorder,
Okay.
actively suicidal,
Uh-huh.
primary substance use, active substance use,
Okay.
and psychosis. Those are basically the things. We can work. We've had success working with level 1 and some level 2 autism
Okay.
in our program.
Mm-hmm.
That's because it's a lot of, for professionals, it's a combination of really heavy CBT, DBT, and resilience model. You
All
put
the
it all
stuff that
together.
works.
Yeah. When I was in residential, half my caseload was borderline-y girls and half my caseload was spectrum-y boys.
Yeah.
And oddly enough, DBT worked for all of them very, very well.
Yeah.
Yeah.
And, those are skills that we're teaching people.
Right.
And
It's skill based.
yeah, and this really is skill-based. And then the fact that it's in a group setting is what reinforces it and helps it become real and workable in my life. Belief that I can do this outside of this room is because I'm doing it inside this room.
So as a therapeutic consultant, your job was to help families find not just the right program, but a good program, because there's good programs, as you know, there's mediocre, and then there's poor programs, right?
Mhm.
When it comes to IOPs, can you talk a little bit about what are the features that set apart an intensive outpatient program as a good quality IOP? And then I guess the second part of the question is, can you talk a little bit more about the anxiety, trauma, and depression treatment centers in relation to that?
Yeah, absolutely. So, of course, it comes down to clinical at the core. I'm a therapist, so of course I'm going to say that, but
Right.
it comes down to how much clinical injection is there in this. And so, for example, our clinicians not only are licensed and graduated, licensed, insured, that kind of stuff.
Hmm.
We have regular rolling training with them by our clinical director, who's a prominent clinician in the area,
Mhm.
which means that it's not necessarily that they're getting their CEOs, it's that every week we're holding a clinical meeting and we're talking about cases and we're talking about how we can make sure that we're meeting the needs of those kids and young adults that are in our program.
So these therapists have ongoing education, supervision. They're
Consultation,
consulting
really.
with
Yeah.
other professionals, different eyes on the case.
Which is a benefit that I used to sell for parents, not necessarily sell, but point out, is that when you have a kid in residential, you have academics talking to clinical, talking to residential, and that tripod. You can't do that in the
Doesn't
outside
happen
world,
in
right?
Right.
It doesn't.
Yeah.
It just can't. And I've had parents try to replicate that after their child has left residential, and it's Herculean, the
Yeah.
task. It's almost impossible. Finding someone who's willing to talk to teachers and teachers that are willing to
Right.
talk to therapists, and it's difficult. You get somewhat of that benefit in IOP
Yeah.
because we're spending so
Yeah.
much time with that person.
It's a team because a traditional outpatient clinic where you're just doing the one time a week, the therapist, I've worked in those settings. The therapist really is an island for the most part.
It's
I
true.
mean, you might have a supervisor that you could do consultation with, but you're really an island. An IOP, it seems like it would feel a little different. There really is a network and a team surrounding that child or that family.
Exactly, and that's one of the benefits that you get when you're a therapist in residential is you have a built-in
Yep.
consultation team.
Mhm.
And
Yeah.
the smart residential programs are promoting a culture, of among those therapists. Ours was a dysfunctional sibling group at the
Yes.
RTC where I worked. We went, made the lunch train and trucked over to the cafeteria every day, and then back to somebody's office to sit and joke and make fun of everybody.
Yeah.
And we had our weekly meetings with the psychiatrist during which we were all cartooning each other and at the same time learning about psychopharmacological options and what's best
Yes.
and available. So, that's really great at the residential level. That's one of the benefits that you have when you're not an island, when you're not a
Yeah.
sole practitioner, when you're not, just a therapist renting office space with a bunch of other therapists that you aren't necessarily going to get, is that consultation. And I think that's really beautiful. And the fact that we do pull parents in, we also have parent groups. Every few weeks, we have the parents come in without their kids, so we can talk to them about how they're implementing at home, how the structure of their parenting it might be affecting their kids' ability to assimilate some of the skills and ideas that they're learning about themselves and the self-awareness. And so it really is kind of a rounded. We've got therapists talking with therapists and with master therapists.
Hmm.
We've got therapists talking with parents. We've got parents talking with therapists. We've got therapists talking with the kids, and we've got the kids talking with the kids under supervision of the therapist.
Them talking with each
Yeah.
other, right? Going back to
It's
that
an
peer group.
ecosystem that
Yeah.
isn't available for your weekly therapy. So it's not just an increase of number of hours that you're going to therapy. It is a completely different breed of cat
Yeah.
because you have the group and the individual and the parent content. It really is amazing.
And I would imagine, I mean, obviously, different programs specialize in different things. Like
Mhm.
in the medical world, you don't go to a general practitioner when you have a very specific issue. You go to a podiatrist if it's with your foot, or an ENT if it's with your throat, right?
Mhm.
Can you talk about your IOP's specialty?
Yeah, absolutely. And just to follow up on that, for examples of IOPs that are different, for years there have been eating disorder, IOP, intensive outpatient. That's that support with the eating disorder issues that you're facing.
Mhm.
And those IOPs, believe it or not, have to have a kitchen set up in them because they have to do that, some of that exposure response.
Yep.
Yeah.
Of being in a kitchen, performing the action of choosing what I'm going to eat and preparing a
That's
meal,
the work.
and then sitting and eating,
Yeah.
and working with a dietitian and a therapist all at the same time. So that is obviously a very individual kind. And it's not that you can't have the same in the same business. It's just that is its very own programming, very specific, separate from something like OCD, where there is a lot of this exposure response prevention.
Yep.
That is almost 100%. And you don't necessarily work with a therapist, you work with a tech who's working with you on your exposure response.
Mm-hmm.
I've toured lots of those, and the kids walk up to you and say, "Hi, I would like to shake your hand, and I'm not going to ask whether or not you washed it."
Right. Yes.
And would you ask me questions about how I think I might die? These are the things that you get from the people
Yes.
that are in these, and it's interesting because that's their fear, and that's what they're working on.
Yeah. So my son, who went to this IOP that focused on anxiety and OCD, one of the exposures is on their break. A bunch of the patients went together to like the restaurant across the street for lunch, and they all had a challenge to do each of them their individual exposure. And one person's exposure was to leave their phone back at the clinic, right? Because that was part of their OCD, and their anxiety had to do with their phone. One was to go and look someone in the eye and start a conversation. One was to just even talk to the person behind the counter, and all these individualized challenges were part of the exposures.
Right.
Really cool.
Yeah. And so it is possible to have these different ones. There is substance use,
Mm-hmm.
intensive outpatient,
Mhm.
which typically is people stepping down from residential to support them in that, because it's just too big a bounce, is the way I've always said. Residential to home and just once a week therapy is just too big a bounce for almost everybody. So we at our anxiety, trauma, and depression treatment centers, we get about half and half, people stepping up and people stepping down. So we get a lot of referrals from Huntsman, from Aspen
Right.
Grove,
Right.
from the Intermountain system,
Yeah.
because that's they need that added support of 9 hours a week. Or some people might step down to that partial hospitalization that I mentioned, where that 8 hours a day isn't necessarily all group therapy. There's downtime. There's some babysitting. There's some homework and school and things that happen during that too. But that's because they need the greater supervision as opposed to applied in IOP, what you're doing. So really those are, I'd say, the main 4 kinds. You have your OCD specific, you have your substance use specific, your eating disorder specific, and then your mental health specific. And we are definitely mental health. Although we do work with secondary eating disorders, substance use, that kind of stuff as well.
But the primary would be mental health, meaning mood disorders, trauma,
Exactly.
those kinds of issues.
Yeah, and I'm a trauma therapist, so everything looks like a nail. That's because when you look at some of the cross-diagnostic symptoms, sadness, isolation, reactivity, aversion,
Yeah.
those are all PTSD symptoms.
Yeah.
Oh yeah, they also have something to do with depression and with anxiety. Anxiety is specifically a symptom of PTSD. And so, of course, I'm somebody who believes that trauma therapy is going to, help knock out everything else. But different therapists see things in different ways. That's been my experience, and that's exactly why we're starting to focus more on trauma.
Well, it's interesting when you get to our level, like in residential treatment level, and you get families who have been brought to us after an acute situation, say a suicide attempt or something, right, where they don't have the time or the luxury to start with outpatient and then move into IOP or whatever. They're just like, they're here with us. And they haven't worked through all of this like deep thinking or really had an opportunity to get a really good assessment, psychological testing, whatever. And if you take one of these students, right, on their intake, and you look at all their symptoms and you put it into the DSM, you could literally diagnose some of these students with 8 or 9 or 10 different diagnoses.
In graduate school, first
Crazy.
semester, we got the DSM.
Yeah.
And the first class was dedicated to, okay, what have you diagnosed yourselves with over the weekend? Because you read through that, and that's me.
you're
That's
good.
me.
And
That's
so,
me.
and so really, having a professional team that is competent, right, and skilled, it really kind of like, okay, this really, even though you hit the symptoms like 8 out of 11 or 4 out of 7 or whatever it is, how many you check off, that doesn't necessarily mean that is what's really going on, right? Because the comorbidity is so, right, the cross section is so interwoven. And that's, I think, the deeper you go into having those teams and the multiple eyes and the time and the difference between outpatient and intensive outpatient, for example, it's just a step towards proper diagnosis and understanding where the dominoes start and where they end, right? Rather than saying, "Oh, I have everything," right?
Mm-hmm.
I have one of my oldest child is also a therapist and worked for us, and wonderful mother and wife and all those things, right? But we tease each other, right? Because she's a self-diagnostic, she's got a new thing all the time. Dad, did you guess what? What am I working on? It's like changing her furniture, in the house. And so,
The new
but
diagnosis.
it's all in good humor, and
Mm-hmm.
and she's functional. It's just like it can be like running down rabbit holes all the time.
It really can. And that is, we consider that to be kind of an issue in and of itself
Yeah,
if
yeah.
you're too preoccupied with that.
Yeah.
And I remember that first class when we had our DSM and we were
Yeah.
diagnosing ourselves, the teacher just made it very, very clear. He said, it's the extent to which you have these problems. Are they negatively impacting
Right.
your ability to function at work, in relationships, at
those
school,
domains.
etc.? And to what extent? And
Right.
so that's kind of a question we ask ourselves also is it enough to get you into once a week therapy?
Right.
Is it enough to get you into IOP?
Right.
Is it enough to? And obviously, traumatic events, when we're talking about a suicide attempt or severe self harm or,
Right.
these kinds of things, or eating disorder, where we're at the point of medical necessity, that is something where you jump the line.
Yeah, for sure.
Obviously.
Yeah.
But it really does come down to how are you doing in your life?
Yeah.
How are you functioning? And especially for these kids, can you see a way forward?
Yeah.
Because most of them just can't.
So, Margaret, I have a question for you, and you're so experienced. You've been doing this for so long and in so many different capacities. As we kind of wrap up our time, think about the listener who's listening to this right now, and they're scared. They're scared perhaps for themselves or for a loved one. They're struggling with maybe a little bit of hopelessness. They don't quite know what to do.
Feeling
Um,
guilty?
Yeah. What is something that you would say to them? What is something you would say to them?
That's interesting that you asked that question. First of all, we see all of our parents as stressed and anxious. No matter how calmly you come across, we know it's raging inside of you because what's going on.
Yeah.
And that's something I've dealt with for decades now. What I would say, and this is the same thing I say to people when they say, wow, how can you do 6 hours a day of trauma therapy with people? And it's the same answer I give people when I was just starting in college, in my graduate practicum, is how can you do therapy? It's because I see hope.
Yeah.
I see hope every single time. It can get better, and it does get better as long as you just keep getting up and going. And, people say to me, what about these people who maybe schedule and then don't show up or come once and don't come again? I said, I'm super enthused by that. That's further than they've ever gotten before. And a lot of people, it takes 6, 7 times to be sober or to be emotionally stable or whatever. I was number 2. Get on to number 3. I'm thrilled with that. And the bottom line is there's always hope. I guess that's the message I would send to every parent, every person who's considering getting treatment is there's always hope, and it will always get better as you take those steps forward.
It's so hard to see that in the darkest of the night, right?
Yeah.
It's so easy to let go of that hope, but that's something that we cling to. That's something that we have the advantage. We see the miracles happen every day.
Every day.
So from our perspective, it will get better. It will get better. But from where you're at, it may not look that way. So sometimes you have to borrow that light from someone else.
Yeah, you do.
I had one of my favorite professors, Dr. Leslie Feinauer, and she was had 2 professions. She was first a nurse and then came back to be a marriage and family therapist. So she was a trauma nurse in Vietnam. So she was the one who would be on the choppers, sustaining life from the battlefield back to the base. And it was that experience that led her into her research on resilience and like who were the guys that could handle that and who were the guys who couldn't. and she dedicated her therapeutic life to resilience training, right, and education. And I'll never forget the very first day in her class as a first, it was actually our second semester. I didn't get her first semester, but she just said that the number one, if you never forget anything I teach you, number one is never give false hope, right? Don't let your own issues of being hopeful, don't give someone false hope if it's not there. And the luxury of what we've been doing, the three of us, right, for the last 3 decades is that we know that it's not false hope, right? Because there are thousands, hundreds. We see people all the time. We watch the success of people who are in the depths of hopelessness. And if they can get the support, and if they can keep at it, if they can learn that resilience, the grittiness, if they can just keep coming back, you can get better. And it's not false hope at all. It is resilience training. It is therapy. It is painful.
It's work.
But it works. Yeah. And you can heal.
This is a nebulous field. And I remember when I first started my training, my dad's a nuclear engineer. And so I wanted a flow chart. I wanted to know if they say this, what do I say next?
Yes.
And it was quickly made clear to me, it is very much an art.
Right.
And that's, when I'm doing therapy, I'm listening to you and I'm over here trying to figure out how to come at you sideways.
Right.
All at the same time, figuring out where we're coming. And the bottom line, it really does come back to what my dad would like. A plus B does equal C.
Yeah.
Willingness plus work does equal success.
Yep.
Just make sure you're getting the right kind of work.
It's funny, Margaret, you say that. I remember being in that class with you, and I remember my shock when I first learned that here I am in therapy school, and they're not going to teach me, they're not going to tell me what to say.
Exactly. They're not going to tell me how to do therapy.
They're going to teach me how to think.
Yeah.
And they're going to teach me how to meet someone where they're at and to guide a process, but they're not going to tell me what to say.
Right.
Yeah.
Well, Margaret, this has been a wonderful conversation. Thank you so much for being here with us.
Yeah, our pleasure.
I would encourage our listeners to look in the show notes, look at the website for the Anxiety, Trauma, and Depression Treatment Centers. It is going through some rebranding right now. But Margaret, you're a exemplary professional. I've known you for a long time, and you're part of a family that's dedicated, has a life mission dedicated to mental health. I know your husband, James, who has his own pedigree and his own career that's been so helpful to so many people. And so I'd encourage you to reach out to Margaret if that's something that you feel like you would need. And I just wish you the very best as you continue fighting the good fight that we're here to do.
Thank you. It's been an honor.
It's a pleasure to have you on our little podcast, and hopefully the people who are listening will be able to take some of your knowledge and apply it to their families. So
thank you.
So that's it until next time. And remember, mental health matters.
That's right.
Thanks for listening. Your mental health journey is so important to us. We'd love your help spreading the word so we can reach as many people as possible. Don't forget to share, like, and subscribe here on our social media or wherever you access your podcasts. Thanks.